Welcome back to Psychiatry Boot Camp. This is Season 2, Episode 9. Wow, how time flies when you're having fun. And if you're having fun or learning anything at all, please pause for a second and leave a rating and review. Today we're venturing into the realm of anxiety disorders, and I thought this would be most helpful to cover as a group of disorders and talk about the general principles of formulation and treatment. Dr. Walkup is a child and adolescent psychiatrist, and I think you'll really appreciate his fresh, honest take on this topic. The developmental approach that he takes to anxiety disorders made a lot of sense to me as a paradigm, so I hope that you enjoy it and find it helpful as well. Without further ado, welcome to Psychiatry Boot Camp, Dr. Walkup, and I will ask you to introduce yourself to our audience.
Hi, I'm John Walkup. I'm a child and adolescent psychiatrist and chair of the Pritzker Department of Psychiatry and Behavioral Health at Lurie Children's Hospital in Chicago. I'm also a professor of psychiatry at Northwestern University Feinberg School of Medicine. I'm in the Department of Psychiatry there.
Okay, so starting all the way at the beginning for anxiety disorders, I think the term anxiety is a clinical term that we use in the vernacular perhaps more than any other psychiatric term. So what is anxiety? What do we as psychiatrists mean when we talk about the subjective feeling of anxiety?
Yeah, this is one that takes a little bit of time, so I'll try not to bore, but anxiety is a normal, healthy human emotion that helps us kind of prepare for the future, to avoid problems going forward. And it also helps us cope with danger. So, anxiety is a huge motivator to study for a test, for example. And anxiety is the thing that makes you ride your bike safely in the streets when there's a lot of traffic. And that's totally normal and hugely helpful. The triggers for normal anxiety are almost universal. So if you think about it, 99.9% of the people are going to worry about taking a test. The prepared you are, the less worried. The worse prepared you are, the more worried. And in busy traffic on a bicycle, you're going to feel pretty vulnerable even if you've got a helmet on. So everybody's going to have those universal experiences of normal anxiety. Now, normal anxiety can also be severe and persistent. So I think about the kids in Syria, the kids in the Ukraine. I think about kids in Gaza and in Israel. Those young people are persistently anxious at an extremely high level with what I would call a normal anxious reaction to extraordinarily awful circumstances. I would never call that pathologic, even if they scored high on a rating scale. But there are some clinicians who would call that disorders of anxiety because they scored high on a rating scale. I'm just not one of them. There's that group that see anxiety and anxiety disorders on a single continuum. I don't. I see anxiety disorders as discontinuous with normal anxiety. And the reason for that is that the triggers for pathologic forms of anxiety are normal developmental experiences. So what do I mean by that? Well, separation anxiety starts between 6 and 12, or the anxiety disorders in general start between 6 and 12 years of age. And separation anxiety is probably the earliest one. But these are kids who really are uncomfortable with age-appropriate levels of autonomy. So while most kids in that 6 to 8 to 10 range really want to become more autonomy, they want to do things by themselves, they want to master activities, kids with separation anxiety don't want to leave the house, they don't want to fall asleep in their bed alone, they don't really like going to school. When they go to school, they end up in the nurse's office with stomach aches and headaches because they want to come home. They're worried about something bad happening to their parents. They can't tolerate a transition to a babysitter. Many kids love their babysitter because they're a lot more fun than their parents are. And so it's important to understand that those anxiety triggers are normal developmental tasks. Kids with social anxiety, they won't raise their hand in a classroom. They won't make eye contact. They don't like to show off. They don't like going to the board to work out a problem in front of others. They won't read aloud. They won't order food in a restaurant. They won't go to parties. So there's this social thing that most kids just love, but kids with social anxiety, it's their most dreaded fear. And then the third anxiety disorder is generalized. And while most kids could care less about what's happening over in Europe or maybe even the Middle East, there are a group of kids who just think that what's happening in the Middle East is going to happen in Chicago or happen in Baltimore or happen in New York tomorrow. That they generalize from disastrous or complicated experiences around the world to what's going to happen in their school tomorrow or in their house tomorrow or to their parents tomorrow. These kids seek a ton of reassurance. And so they're constantly asking questions. And when parents try to reassure them, they can't reassure them. So, a lot of kids will say, well, geez, what's going to happen? And it's like, it's going to be okay. And the kid goes, okay, it'll be okay. These kids say, no, it won't. Let me do a follow-up question to that. So that's what the pathologic form of anxiety looks like, in the sense that the triggers are normal developmental experiences that most kids either love or tolerate extremely well. And that difference between kind of normal anxiety, which is triggered by things that are universal, and pathologic forms of anxiety that are triggered by normal developmental activities is the thing that differentiates them. As a medical student or early career psychiatrist, this is what medicine's all about, right? You have vision and blindness, you have hearing and deafness, you have smell and anosmia, you have cardiac function, you have arrhythmia. Every kind of normal physiologic process, you have a pathologic form. And if you think about it in psychiatry, we have the same thing. Cognition or IQ is dementia, or memory is dementia, if you will. Perception is hallucinations and delusions. So if you think about what we do in this business, we are preoccupied with pathologic forms of things that are otherwise normal in the vast majority of human beings. So I do this with depression. So normal human sadness is extremely common, and it can be very severe given the stressor. And we also have demoralization, which is the kind of chronic, persistent pattern of unhappiness related to adverse life events. And then we have this thing called clinical depression. And most people with clinical depression can differentiate it from normal human sadness or from circumstances that they may live in, which are adverse and uncomfortable. And they differentiate the feeling of that mood, the clinical depression, from those other forms of sadness.
Well, that was not boring at all. That was an amazing summary of exactly what I invited you here to talk about. And I think kind of the core of what I'm hoping to get across in this podcast is that we are not here to pathologize normal human behavior. And I think you offered an excellent example of that. Just kind of a listener note, we're recording this on October 30th, 2023. So hopefully some of those global examples that you gave, God willing, will change by the time this is published. Yeah, hopefully. And then you walked us through separation anxiety disorder, social anxiety disorder, generalized anxiety disorder a little bit. So when we're looking at, drawing this line, making a distinction between normal human emotions of anxiety and what we might call an anxiety disorder, it sounds like you're telling us that the GAD-7 alone is not going to be enough.
Well, the GAD-7 is an interesting measure because once I make the diagnosis, I actually use the GAD-7 for following. It doesn't make the diagnosis, but it gives me an idea of severity in someone who is diagnosed. And the reason for that is because it does pick up some functional impairment of those strong pathologic anxiety feelings. There are other rating scales. There's the dimensional anxiety severity scale or something like that, the MASC. It picks up a lot of extreme normal anxiety and mushes it with pathologic anxiety. The SCARED scale for anxiety and related disorders or something like that, it was published by the folks at Pittsburgh. That's actually tied to DSM criteria. And so it captures a little bit more of the disorder look to it. But a lot of rating scales are based on this idea, this dimensional idea of anxiety. And there's some reasons for that. Investigators, scientists really like dimensional rating scales because dimensional rating scales give them a ton of statistical power. So if you have a sample with 0 anxiety, 5 points, 10 points, 15 points, 20 points, you have that range of anxiety severity, then you can put that into a logistic regression with, neuroimaging study findings and have a very small sample size and identify correlations, if you will. Whereas if you have a yes, no, anxiety disorder, yes, anxiety disorder, no, you lose a ton of statistical power. So part of the National Institutes of Mental Health, the whole RDoC movement, research diagnostic criteria movement, is to create any range of dimensional ideas that can be scaled up so that you can begin to make associations with degrees within a variable as opposed to the yes and no of a variable.
So our different screeners that we have can be helpful for picking up patients who may be experiencing these symptoms, for tracking progress over time. Certainly absolutely crucial for developing evidence, but in and of itself, they do not make the diagnosis.
Yeah, yeah. I mean, the other part for me, and I work with a lot of pediatricians, after you've done an anxiety rating scale 20 times, if you don't kind of have it memorized, or if you haven't figured out what that rating scale is supposed to capture in the patient in front of you, and you actually have to, do the rating scale kind of like you do a, electrolytes panel. You don't know what the person's sodium is until you draw the blood. If you don't know whether the person has an anxiety disorder or depressive disorder until you do the rating scale, you've kind of missed the point of the rating scale. The rating scale should teach you what the phenomena is that you're looking at, what the pattern is. Because physicians, by their very nature, are pattern recognizers. And rating scales exist because there are patterns. And at some point or another, you got to look past the rating scale to really know, are you really good enough in talking with patients, listening to their complaints, even when their complaints aren't specific to the disorder, they're about something else. So, for example, many young people with depression don't talk about feeling sad, down, and blue. They talk about how their brain doesn't work and that they just feel like they've lost their capacity to be cognitively astute. When I hear that in a 25-year-old, that's clinical depression. They don't have to talk about sad for me. They can just talk about how their brain just doesn't seem to work, and they're scared to death of that experience. That's what depression really looks like.
Yeah. So you're talking about using our tools as tools and then using our professional judgment to decide, like that, an MDD, the criterion of low mood. You don't necessarily have to say, doctor, I feel depression or I feel a low mood. Someone can explain that to you in other words, and we can use our clinical judgment to make the diagnosis.
Yeah, because I've had families of kids with separation anxiety who describe it as homesickness.
Huh.
When he goes to school, he gets homesick. When he goes to grandma's, he gets homesick. When he tries to do sleepovers, he gets homesick. As a matter of fact, he even gets homesick within our own house. When I'm in the kitchen and he's in his bedroom, he gets homesick for me. And I'll say, no, that's separation anxiety. And they say, no, why are you calling it that?
Right.
It's really just homesick.
Mm-hmm.
And kids who are shy, because that's a word that's sometimes used for social anxiety, but most kids with social anxiety are extremely self-conscious. They think other people are looking at them and judging them all the time. And that's different than shyness, if you think about it. So I use any number of terms to kind of capture what the feeling or experience is of the anxiety disorders.
So one of my goals with this podcast is to try to keep things really helpful for our learners who are in the clinic, seeing patients every day. Do you have any clinical tips for a learner about how to build a therapeutic alliance with a patient who is quite anxious?
That's a really good question. One of the most interesting things to me is that pediatricians form relationships with their patients really, really quickly. And the way they do that is they do it through kind of some combination of good listening skills and kind of carrying a sense of competence and knowledge about stuff that gets presented in the office. One of the things I think that is a disadvantage of psychiatry training is we kind of ask psychiatrists to become kind of blank, not to become too personal, become kind of neutral, and not necessarily to demonstrate that you know a lot about psychiatry, but to kind of lay back a little bit and let the patient kind of explore your knowledge through some other kinds of means or methods. And I actually think that that does patients a disservice because when you're really blank like that, they don't know if you're any good or not. And so for me, modeling after pediatricians, good internists, good family docs is really what most psychiatrists should be doing because they form really, really strong relationships with their patients really, really quickly through that kind of engagement process. And sadly, I think a lot of our training kind of buffs that out of most early career psychiatrists. They're afraid of being a little too professional in the moment. So that's it for me in terms of forming those relationships. The other thing, as an expert, I have a ton of content knowledge about the anxiety disorders, as people can probably tell. Much of what I've said today, I've said 1,000 times to patients and in lectures and in other places. And patients love that kind of information and that kind of material when you can do a little chalk talk or provide a little of that kind of information, particularly if you can relate it to the narrative of the kid in front of you. Like you just told me your kid really has trouble when you're a different room of the house. And it's like, yep, I've heard that a million times. These are kids who have problems going to grandma's, problems doing sleepovers, at school. They think about coming home. And the families will say stuff to me like, that was our house last night. We were talking about going to grandma's and he doesn't want to go to house. When I can kind of lay out that narrative like that demonstrate that I know what they're talking about, that also builds confidence really, really quickly.
So you're sounding a lot like Dr. Alan Francis in episode 1 of the entire series when he's talking about how depending on the patient and the diagnosis and the formulation, you really have to follow that patient and not rely on sort of general folk ideas of what a doctor should be. So for patients with an anxiety disorder, your advice is, we are experts. I've been in school my entire life for this. It's okay to demonstrate that competence, whether it's drawing a graph of maybe rebound anxiety and substance use disorders, I think is a really helpful one for patients, for repeating back to them and then even going further and saying, and I have seen a lot of other patients with this problem, and they often tell me this, 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 and this. Is that right? And the patient might say, oh my goodness, this person actually knows what they're doing, and they might be able to help me. And then that can kind of help us actually form a therapeutic alliance and maybe even get better outcomes.
Yeah. And, I mean, I was trained when a patient asks a question, it's like, well, what do you think about that? That's a very shrinky thing to do. And it may have some value because on some level, patients ask questions, and more often than not, they are statements. But I think every once in a while, if you can kind of do a little chalk talk or a mini spiel that really gets to that. I also think sometimes, and I do this maybe more than others, I not only know what patients look like in cross section, but I know how their symptoms evolve over time. And I know the kinds of impairments that they're vulnerable to over time. So I talk a bit more about prognosis than many people do. And sometimes families will say to me, you told us about what might happen in the future. And that makes total sense because we've talked to some other people who have had this problem a little bit longer, and they described exactly what you said is going to happen. It's happened to them, and we don't want that happening to our kid. So there's things like that. There's things like that kind of also build credibility very, very quickly.
Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I use to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word bootcamp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all in one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. So, on that note, thinking about the development of anxiety disorders, what do we know about how anxiety disorders develop? Do we know what types of things can quote unquote cause them?
Well, this is a problem for me because I think they're genetic and the pathologic forms have a very, very strong kind of biological component to them. Yet, if you read the literature, you'll hear about, prominent separation events like divorce of a parent can cause separation anxiety. When I read those studies, I think, well, yeah, that may be. If you look at a bunch of kids with separation anxiety, you're probably going to have maybe 50% like the divorce rate where there was a prominent separation due to divorce. Is that causal? Or did that become salient in the context of a pre-existing anxiety disorder? I think there's stuff like that when we look at these kinds of risk factors. Overprotective parenting is another thing that people talk about as causing anxiety. It's this idea that if you look at your kid and you say, "Are you okay? Are you okay? Are you okay?" You can actually make your child anxious by asking them too many times whether they're okay. At some point, the kid says, "I must not be," because you keep asking. That overprotective parenting, could it be a cause or could it be a secondary phenomenon to having a youngster who's extremely anxious, where you have to hover to protect them because you're worried about how they feel? So a lot of that stuff, at least in my mind anyway, those kinds of studies are really a problem of this dimensional look of anxiety, right? Because people look for those dimensional aspects of anxiety and then correlate it with these kinds of parenting attributes or styles. The one thing that I am particularly interested in, your listeners may find kind of interesting, but Don Klein, may he rest in peace, was one of the first people to really start talking about panic disorder and defining panic disorder many, many years ago. And he came up with this idea that we all have a suffocation alarm in our brain that is tied to PCO2 levels. And if you think about it, if you go to the top of a mountain, your PO2 level can drop well under 100, but you don't feel like you're going to be breathing harder, but you don't feel panicky. Whereas the PCO2 level is highly conserved. So, if you go to 41 or 42 or 43, and if you've ever worked with people with COPD and they start getting up to 45, 46, these are some really anxious human beings. And what he was suggesting was that in people with panic disorder, their PCO2 suffocation alarm was set at 39, let's say, or 38. And so if your physiology is keeping you at 40 and you're constantly triggering that suffocation alarm because you're at 40 and your trigger is misset at 39, you're going to be pretty uncomfortable. And there have been a series of studies where, as a challenge test, people have actually been asked to breathe elevated levels of CO2. And I actually did that at one point. And you put a mask on and breathe a higher concentration of CO2 than you otherwise would. And the experience I had was really rapid and extremely intense. And it was all panic, it was all fear. I thought I was going to die. And I wasn't going to die. I was just, but it's that feeling you get when you're underwater, like snorkeling or something like that, and you're kind of getting to the end. That's not a shortage of oxygen because you could probably live much longer, but your PCO2 is beginning to rise and it's beginning to trigger that threshold. And so that physiologic thing, I think, maps on to another part of the literature with respect to panic disorder, that it's not really a fear-based problem. So it's not a cortisol, amygdala kind of fear-based problem, but it really is a respiratory issue. And I like that because it helps me when I'm working with people with panic disorder to reframe what it is that they're experiencing from something that's about anxiety, which they deny because they think they're going to die and it must be something else. And so when I use the word anxiety with them, they say, I know what that is. That's what I have when I take a test. This is different. And panic really is different. It's qualitatively different and it's much more intense. And so when I describe it as something as part of respiratory physiology, it helps people disentangle that kind of normal experience from anxiety from panic.
Well, and not only that, but you're also providing useful treatment in that psychoeducation, right? So when you're helping the patient to understand where their symptoms are coming from. So do you actually go in with patients? Will you talk about CO2 and PCO2 and explain to them, no, it feels like it comes out of the blue. It's mischaracterized as anxiety, but this is really, you'll get that into the weeds with them.
Yeah, there's even one beautiful study from many years ago where they interviewed a bunch of panic disorder patients about where they have panic, right? And so where is it? Elevators, closed spaces, theaters, churches, and malls and things like that, like agoraphobia. And they went there with big plastic bags and they captured ambient air, and then brought it back to the lab and measured that in many of the panicogenic environments, there's high ambient levels of CO2. So, it's just another little piece. People understand that makes sense because usually people panic in certain situations. I think about people who pull covers over their head and rebreathe their own CO2 at night and then wake up in the middle of the night with panic. So I talk with people about panicking in the middle of the night and are their doors closed? They have windows open, just kind of what might be in their room at night that might elevate the amount of CO2 that's in the ambient air within their bedroom. And again, if they say, oh yeah, I always pull the covers over my head and I keep the door closed because it's a norm and I never open a window because I'm afraid of germs or whatever. Okay, so yeah, you may be rebreathing your own CO2 and causing yourself to panic in the middle of the night. Get a fan and get some fresh air in your room and see whether you can kind of avoid doing some of that. So it's things like that again, that content knowledge with good interpersonal skills can make a huge difference in patient care.
With regard to your comment on the genetics, in my lit review, there was a Lancet seminar on anxiety disorders that had GAD as about 35% heritable, social anxiety disorder, panic disorder, agoraphobia, about 50% heritable. You think those might be underestimates?
Well, the thing with anxiety disorders is that if you look at twins, which is I think I like it a little bit better because what I worry about with some of those studies is that anxiety, normal anxiety at severe levels, if you will, may get conflated with the pathologic forms. And so when I think about kids and twin studies, what you see there is that monozygotic twins, identical twins, have higher concordance rate than dizygotic twins. But dizygotic twins have probably higher rates of concordance than they should because you have some estimate of what siblings should have from a strictly genetic point of view. And it's much less than what identical twins would have. So there is some suggestion in the twin studies of anxiety that there is this environmental or shared environment kind of feature of it. And certainly for medical students, and I use this example, you're studying really hard, in the library or something like that, or in the dorm room or wherever you are. And one of your classmates comes in and says, I just talked to somebody who took the test last year and this professor is a real bear. And he asked a bunch of questions about stuff that they never lectured on. And, have you guys read anything about this yet? And I haven't done any studying and the test is tomorrow morning at 8. And what do you think? And should we all sit and study? And what should we do? And anxiety is contagious. And in medical school, it's not difficult at all to make one of your colleagues really anxious by asking a lot of questions about stuff that they weren't thinking about or weren't prepared for. So certainly that happens within parent-child dyads. Kids can make parents anxious and anxious parents can make kids anxious.
Perfect. So you kind of alluded to this earlier, but what are some concrete ways that anxiety can impact people's lives? So like this functional impairment that they experience, what does this look like? Another way to ask this would be like, what are some experiences that patients might report that should clue us in that we need to start thinking about an anxiety disorder?
Yeah. That almost universal coping strategy with anxiety is avoidance of the trigger. So for kids with separation, they avoid separation events. For kids with social anxiety, they avoid social events. What happens though with the avoidance of separations and the avoidance of social events is you're essentially taking kids out of normal developmental tasks that are absolutely necessary for transitioning to independence over the next decade. So, what we tend to see is kids avoid, so they fall behind in terms of interesting. Social anxious kids fall behind in terms of language because they don't talk. They fall behind in terms of socialization and social skills because they don't socialize. Similar with kids with separation, they don't tolerate being away from or being out of a dependent relationship with a caretaker. And they also fall behind in terms of socialization because they're hanging out largely with parents. Their language isn't quite as impacted. Both groups, including the generalized worriers, they prefer academic subjects that don't have a right answer. So if you think about mathematics is required, you got to have a right answer, right? Anxious kids get really tight when the content requires the right answer because these kids worry, is that the right answer? Am I sure? Am I really sure? Am I confident? Is it really right? I better double check. That kind of mulling, if you will. They love poetry and history and writing where there is no right answer, but they can use their brains in that way. But anyway, getting back, what you essentially see is kids avoid social, language, and opportunities for independence. And if you do that, if the anxiety disorders start like I think they do between 6 and 12, and you do that untreated until you're 15, 16, or 17, you're going to have upwards of 8, 9 years, or even more than half of your life, where you haven't really taken on the challenge to function independently, to form relationships, and to use language to engage and solve problems. So what we see in this older adolescent and young adult population are a whole group of kids who are beginning to fail in that transition, that individuation transition. And some of them get suicidal, some of them cut, and some of them, not the separation anxious ones, but the GADers and the socially anxious ones, sometimes learn that alcohol will make them a little bit more comfortable with their kind of pattern of worry. So these are a group of kids who may head off to college and then not make it through the first couple of months and have to come home. They often get misdiagnosed as clinically depressed because if you think about it, you've been uncomfortable with anxiety since age 8. You're 16, 17, and 18, and you still have never been treated. You don't have good coping skills. You don't adapt well to complex environments. You're struggling to make the transition to independence. You're going to be pretty unhappy. What these kids don't have is pervasive experience of inability to experience pleasure. So if you take them out of those anxiety triggering events, like you bring that kid home from college and he lays on the couch and is happy as a clam. So he doesn't look depressed once he gets home, but boy, oh boy, when he was at college and failing to function because he doesn't have good adaptation and coping skills, he's really, really miserable. The other thing that kind of accelerates this whole process are parents who accommodate. So if you think about a child with separation anxiety who's made the decision that the reason why they're separation anxious is because the school teacher is a bad person and the school is not sensitive enough to their child's needs, and the nurse is kind of mean because the nurse wants to send them back to the classroom as opposed to send them home. And the parents decide that what they want to do is bring them home and start doing homeschooling because the school situation is terrible and mean. That conveys a very powerful message to that youngster about their feelings of separation, validating them in a very robust way and reinforcing that through accommodation. So that combination of avoidance coping with anxiety triggers over time and parental accommodation essentially is really, for me, the crippler of the anxiety disorders, because people with anxiety really don't develop the adaptation and coping skills that the rest of us develop just by banging around in the world.
Right. So when we're having a discussion with the patient and we're picking up this sort of negative reinforcement where the absence of the stressful situation is making them more likely to continue to really avoid things, is sort of what you're getting at. That is what will kind of initially indicate that we might be dealing with an anxiety disorder. And I adore your point about the misdiagnosis of an anxiety disorder as MDD. And I think the same logic can apply across the diagnostic spectrum. I think it's a mistake that's made all the time, especially in 15-minute primary care appointments where you only get to give a screener. And this is not a failure of any one person in particular. This is the unfortunate reality, I think, of the system that we're operating in.
Yeah, they're very unhappy because their lives are miserable and very small, but they're small because they're avoiding most of those activities, not because they're not pleasurable to them. They're avoiding them because they're scary and uncomfortable. People confuse avoidance behavior with social withdrawal. People with depression are not avoiding, they are just withdrawn and shut down. They don't have the energy. Whereas people with anxiety want to go do that stuff, but it is so uncomfortable and so painful for them. They flood, they get overwhelmed by routine developmental experiences. And that's when they learn to cut, right? Because that flooding, overwhelmed experience is what cutting actually makes feel a little bit better. That overwhelming distress goes away when people cut, another negative reinforcement kind of pattern. So, in that kind of young borderline population is a whole group of young people that I think of as anxious, not as clinically depressed, but they are unhappy. They just don't have that kind of different quality of mood that you see in people who have a major depressive episode.
That is just clinical gold for us. That's wonderful. I was going to ask you about any comorbidities that you think we should be thinking about in patients who are anxious. It sounds like you are really reminding us to think about what is the primary functional impairment, the primary cluster of symptoms that is leading to the functional impairment. But any other comorbidities that you think need to be on our radar when we're seeing patients with anxiety disorders?
Well, I joke and say I don't believe in comorbidity anymore. And then the reason I say that is not because it doesn't happen, but the true co-occurrence of two independent conditions is pretty uncommon. Even common conditions like ADHD and anxiety. Much more commonly, what we see are kids who are anxious who get misdiagnosed as having attentional problems because they're worried all the time that they can't pay attention at school. So they don't really have an empty brain that is distracted by outside stimuli. They have a full brain, but the brain is full of worries and fears. And so it makes it difficult for them to pay attention in the classroom. And sometimes when they work really hard to pay attention, they actually freeze up and their brain shuts down. That's so different than what you see in ADHD. But you'll see a lot of kids who say, I have ADHD and anxiety. And we re-diagnose those kids as, no, you don't really have ADHD. You have an anxiety disorder that's making it difficult for you to think because your mind is full of fear and worry. The other thing is that this evolution of anxiety plus avoidance coping plus parental accommodation, that does lead to kids who really develop substantive identity disturbance because they don't know who they are. They end up cutting. They end up with substance abuse problems. They end up with all kinds of stuff when they're 16, 17, 18, 19. And if you look at them at age 19, you would say they have ADHD, they have anxiety, they have a substance abuse problem, and they have incipient borderline personality. When I look at that, I say, yeah, you actually have the typical outcome of a kid with an anxiety disorder that's never been adequately treated. And so your accumulation of adaptation and coping problems, your risk for self-injury, your substance use is all a complication of your underlying anxiety disorder. They're not new conditions, if you will, that you just happen to get. They are really the outcomes of the fact that you've had a condition that really has never been adequately managed.
That is phenomenal, and I think it's a take that is not taught often enough,
No.
across various professions that are working in the mental health space. I mean, if you just look at, and we try to stay away from DSM criteria on Psychiatry Boot Camp because our listeners can read that for themselves. But I mean, if you just look at like criterion C, right? It's six or more. The anxiety or worries associated with three or more of the following six symptoms. One of those is, quote, difficulty concentrating or mind going blank. And when I scroll through social media now, these social media posts want me to think that just having that single criterion means that you qualify for a clinical diagnosis of ADHD. And if I just go to one of these websites, I can get stimulants mailed to my door in like 60 seconds. You know,
Yeah.
that's what our society is telling us mental health treatment is right now. So I really appreciate you adding some nuance to that conversation.
I mean, if you apply the model that I just applied, that there is no comorbidity, you have a teen with depression and they had decent premorbid functioning. Depressed kids fall behind academically and they fall behind socially. So what's going to happen is their academic performance is going to decline and their engagement in social activities is going to fall apart. Well, you do that for 4 or 5 cycles of a depressive episode, and now you're in college, you're going to fall behind in your social capacity and you're not really going to be ready to work. And because depression oftentimes is worse in the winter, you may start off in September doing pretty well academically. But by the time winter rolls around, you're going to get into the kind of depth of your mood disorder and you're going to fall behind even further. You have 4 years of recurrent depressive episodes. Your academic decline may actually change the direction of where you want to go with your future from what you thought about, and your socialization is also going to be impaired. The other thing about having these conditions and not having a diagnosis is that people with depression and anxiety, to some extent, want to keep it secret in their intimate relationships. And so their ability to reach out and fall in love and develop close friendships, if this is really something they want to hide from others, it means that they kind of have to keep away from intimate relationships where they have to share the fact that they've struggled at various points in their life. And so they also miss out some of the real excitement in terms of developing meaningful relationships as they transition to independence and young adulthood. It's hard to fall in love when you got a secret. And so many aspects of what we see in this young adult population is really not related to the disorder per se. It's the accumulated impairment from the lack of treatment and the impact that it has on people's growth and development.
That's absolutely wonderful. So you've alluded to this now several times, the importance of getting the correct diagnosis, getting the correct evidence-based treatment. You're kind of implying that when we look at this cumulative functional impairment, by making the right diagnosis and getting the evidence-based treatment early, we can make a huge difference in someone's quality of life. So let's talk a little bit about the treatments.
Yeah.
What do you think any psychiatry intern should know about psychotherapies for anxiety disorders?
First of all, just based on everything we just talked about, I always think of 3 levels of treatment or 3 tiers. So our evidence-based practice is always focused on tier 1. So reducing anxiety or depressive symptoms. Okay. We never really in our randomized controlled trials focus on level 2, which is the accumulated impairment. So again, if you're 17 years of age and you've had an anxiety disorder since age 7, you've accumulated a lot of impairment. So I can help you get rid of your anxiety symptoms, but the fact that you've lived a decade avoiding things and your parents have been accommodating, and that you're maybe 5, 6, 7 years behind in terms of your social skills, your ability to use language to form relationships, your capacity to become intimate with others, those things ain't there. And they are a subject for good psychotherapy. And I even sometimes call it rehab. Because if you think about it, if you've been ill for a decade and you finally get treatment and your primary symptoms are under control, you probably need to do a little rehab in order to get your full function back. So that's level 2. And then the third level is really, some of these patients are at fundamental risk for maladaptive stuff like suicidal behavior, self-injury, substance use. And so if you have a 17-year-old who had anxiety at age 7, they have anxiety symptoms, they have accumulated impairment, and they may have a bevy of maladaptive behaviors like suicidal thoughts, self-injurious behavior, substance use. So your treatment plan has to consider all 3 levels. And so I do that for depression. I do it for ADHD. I do it with autism, believe it or not. If you think about the life of children with autism, they have a autism has a life course to it. A good friend of mine, Chris McDougall, is just opening the first geriatric clinic for people with autism because that life cycle has a whole bunch of issues if you're autistic. So thinking about it that way kind of sets up the treatment. Our treatments are really good, but they're really level one treatments. We just don't have great treatments for level two or three. That said, treatments like DBT, dialectical behavioral therapy, is really good for level three, right? Self injurious behavior, suicidal thinking, maybe some substance abuse risk, all that maladaptive pattern of behavior, and maybe some relationship instability due to poor kind of adaptation and coping and an inability to form close relationships. That borderline-ish presentation does respond to DBT, but in my model, level three treatments without paying attention to whether there's some level one disorder driving level three means that we'll do a lot of work at level three, maybe even do some work with coping skills at level two. But unless you get to the genesis, which is the underlying anxiety or depressive disorder, you're really not doing that patient any favor by just doing DBT for the end stage symptoms of a disorder that never got treated. I hope that makes
It
sense.
makes perfect sense. It's a fresh take for me. It's not kind of the way that I had been formulating things in my mind, but I totally see your point.
Yeah, I'm always doing the fresh take.
Could you tell me a little more about, so, you want us to not overlook level one. So what are the psychotherapies that we should be aware of for level one?
Yeah, I mean, you know what? That there's a I think there's a couple of things about psychotherapy for anxiety disorders. It's exposure, it's exposure, it's exposure, it's exposure, right? So when I think, what does that mean? That means like if you're separation anxious, what we do is we work with parents just to do 1,000 separations a day of low intensity, low threat until the kid gets so comfortable with the parent coming and going and coming and going that they just begin to ignore it. And then we graduate to out of home exposures, then go into school exposures. And, it's progressive desensitization and it's exposure. It's the same thing for social anxiety, but sometimes social anxiety actually requires a group effort because it's very hard to have the one on one therapist patient relationship and do all of the kind of exposure tasks that need to be done for people who have social anxiety. They need a party, they need to present in front of a classroom, they need to order food in a restaurant. They need a kind of a milieu around them in order to kind of do their full on exposure. The problem is that many of these kids also have co-occurring generalized worry, which and generalized worry sits largely within a person's head and rarely has any kind of target for avoidance. So if you think about it, if you're worried about the future, if you're worried about the past, you can sit in your own mind with that forever. And the only thing you can do is self-talk. And so self-talk, which is a valuable thing, like, yes, the world is not going to come to an end tomorrow. Um, it is really, really hard to get inside that person's head and get them to do that self-correcting thought. Can be done, but it really requires someone who's super motivated and understands that their mind is playing a trick on them, that these are thoughts that come from the disorder, they don't come from them. But many people who are anxious are worried about the test, but to the 10th power. They're worried about the war in Israel and Gaza to the 10th power. They have a kind of a core kernel of worry that's reasonable, but they just can't manage it or control it. It's very difficult to do exposures with those folks. So as I'm listening to patients, when I hear a big generalized worry pattern, I tend to think about medicine because usually there's some physiologic symptoms that come with that, like decreased sleep, inability to fall asleep, I should say, a lot of somatic symptoms, things like that. So I medicate most GAD patients with SSRIs and think about exposure-based treatments for kids with separation and social because there's a core there. The issue in the very best hands with CBT, it doesn't commonly take people to full remission. And so in our big anxiety disorder study of kids, we got the full remission 65% of the time with combined treatment. And with CBT only at 12 weeks, we only got 35%. So That's a 30-point difference between combination treatment and CBT only. And I know the world likes CBT as the place to start. There's no data to support that, but we like that anyway. And people don't like to use medicine. But I think you really put kids at risk when you put them in CBT and you don't have the goal of remission, particularly within 12 weeks, maybe 18 at the outside. So if that kid isn't in full remission of anxiety disorder symptoms by week 12 to 18, that kid's got to take med. But our world isn't set up like that. Not every psychologist comes with a prescriber. Not every therapist comes with a prescriber. And so what tends to happen is kids tend to sit in treatment perhaps too long. The other thing is that we have learned from a couple of studies that kids who don't get better with their first treatment, rather than say, oh my God, I'm refractory, I need a better person, I need more treatment, I need to double down and invest. Actually, what happens if you don't get better with the first treatment, you drop out because treatment's not meaningful. So when I talk with early career psychiatrists, I say, you got one chance. You got to get them well with that first chance. This idea of start low, go slow, start simple, wait for complex, wait for people to fail treatment. When you wait for people to fail treatment, they don't trust you because you offered a treatment that failed. And unless you have a plan to kind of incorporate the fact that you're going to step up care at a certain point in time, they're going to hear your suggestion. Well, I guess we have to add med now. When you add that, you're going to lose credibility because you didn't talk about adding med back before, and you didn't talk about the risk for failure back before. And so you lose credibility as a treater when you don't talk with people about, we're going to do it for 12. This is your chance of remission, which is 35%. If you don't remit, we're going to add med, going to reevaluate you at 24 weeks. By that time, we anticipate that maybe 60% of kids who didn't remit with psychotherapy alone are going to reach remission, but it's going to be at 24 weeks. That kind of an explanation to patients is very compelling, particularly